the respiratory zone here. This is kind of where the magic starts, right? The actual process of exchange of gases. And so we're seeing gases move in both directions. So don't forget that we got oxygen moving into our capillaries, CO2 moving into the alveoli, that exchange of gases, right, moving in both directions. And this is really where we see this happening via diffusion. And so as we've spoken about in other parts of our physiology, anywhere that there is diffusion, there needs to be a membrane that is adapted or suited for diffusion. And that means there need to be very little stuff in the way, very thin cells, as well as a very thin membrane in order to facilitate that exchange. Some of the structures here in the respiratory zone are the respiratory bronchioles. We've also got the alveolar ducts, the alveoli themselves, and then the alveoli actually form into these clusters that are called alveolar sacs, okay? And just to point out a really important difference between the border between the terminal bronchiole, which is part of conducting zone, and the respiratory bronchioles, which are part of respiratory zone, is that the respiratory bronchioles are sometimes studded with alveoli themselves, okay? Really, the beginning of where we can start to see that exchange is the functional difference between conducting and respiratory zones. Again, just to point out here, we have very little cilia and smooth muscle, almost negligible, and no goblet cells and absolutely no cartilage found in this region. Okay, moving on here. So again, main function being the exchange of gases via diffusion. And so again, just to point out the difference between the terminal bronchiole, which is a part of the conducting zone, and the actual respiratory zone, which includes the respiratory bronchiole, alveolar ducts, alveolar sacs, which include alveoli themselves. And the main difference between these two structures is really that the respiratory bronchioles are sometimes studded with small bits of alveoli. And so we can start to see some exchange taking place here. And so the respiratory bronchiole does start to constitute the respiratory zone. All right, getting into the alveoli, right? This is actually where we see exchange. This is the site of that gas exchange. There are many, many, many alveoli, about 300 million alveoli in the lungs. That's per lung, that is. And so when we stretch that out, that gives us a combined surface area that's about the size of a tennis court. So a lot of surface area for gas exchange to take place. Another thing that facilitates that gas exchange is the rich vascular supply, that rich network of capillaries that covers the alveoli, that forms the sheath that overlays the alveolar sacs, okay? We've also got alveolar pores located among these alveoli. So if you look in the middle here, in the center of these alveoli, we're seeing these tiny openings. And the purpose of these openings, we'll talk more about this when we get into the mechanics, but the purpose of these openings is to allow one alveoli to communicate to its neighbor, right? This is going to equalize the pressure that's existing within an alveolar sac. And so that's going to be really important because, as we'll see later on, the pressure that exists within these alveoli creates the gradient that facilitates the movement of air in and out of the lungs. Just like we talked about in terms of that bulk flow, the pressure gradient being the driving force for blood, we'll see here later on that the pressure gradient is also the driving force for air moving into and out of our lungs, okay? And so to equalize the pressure that is found within an alveolar sac, we have these alveolar pores that allow one alveoli to communicate to the next. I'll talk about the alveolar cells, the type 1 and type 2 alveolar cells on another slide down where we can actually illustrate those. Okay. Now here's a few images that kind of really highlight that rich vascular network, like lots of capillaries found here, just as much as we see lots of surface area on the alveoli. Really, these two structures are adapted for that increased exchange of gases. So on the left, we're seeing the branching of these capillaries, as well as the branching of our bronchioles. So although we can't really get a good appreciation of how much branching happens within the bronchial tree right further down into our lungs, we can really see that appreciated here. Lots of branching of our terminal and respiratory bronchioles and lots of capillaries that are coming into contact with those alveoli for lots of gas exchange, okay? On the right, we're seeing a similar thing, right? We're seeing the alveoli sort of studded in between, but lots of vessels, lots of rich capillary networks that are facilitating that gas exchange. Okay, so we'll talk about the alveolar cells here where we can sort of illustrate them a little better. So the type 1 alveolar cells are what make up the wall of an alveoli. So these are these lining cells that are found here, the type 1 cells. And they're going to have a very thin membrane. These are a single layer of epithelial cells, much like capillaries, right? That very small width to allow for exchange of material. The other type of cell that we see here are the type 2 alveolar cells, and these have an important role in that they secrete surfactant. Anyone remember surfactant from Unit 1 of last semester? Anyone remember what type of molecule surfactant is? Just kind of a throwback question here, away from Unit 1 in semester 1. We talked about surfactant a little bit as one of our biomolecules. Anyone can remember what type of biomolecule that was? Okay, so maybe not. So surfactant is a phospholipid. And if you remember the nature of phospholipids, right, they're amphipathic in that they have a polar head, a non-polar tail. And so that is going to really indicate the function of surfactant in the alveoli. Surfactant is going to take over the role of what we saw cartilage do in the upper airway, what we saw smooth muscle do in sort of the intermediate airway, in that it's going to help keep the alveoli open, right? It's going to help keep the alveoli patent and open and prevent them from collapsing on themselves. And so while we've lost most of those structures coming down to the distal part of the airway here, we've lost cilia, we've lost goblet cells, we've lost cartilage, we've lost smooth muscle. The surfactant is going to help take over the role of what cartilage and smooth muscle does in the proximal part of the airway, and it's going to actually help keep the alveoli open. It's going to increase the surface tension, and we'll talk about how it does that later on, but really prevent those alveoli from collapsing. The other structure that we see here, or cell that we see here, are the alveolar macrophages. And macrophages are one of our leukocytes. They are extravasated from the blood. So when they leave the blood, they become macrophages. And when they're in the lungs, they have a role of sort of taking over from what the goblet cells and the cilia did in the upper parts of the airway. They're going to have an immune function. They're going to trap or engulf any type of debris, any airborne pathogens that by chance have made their way all the way down to the respiratory zone and into the alveoli themselves. So the important takeaway message here is that because we want to eliminate the bulky structures that prevent gas exchange, such as cilia, goblet cells, mucus, smooth muscle, and cartilage, because we eliminate that for the ability to transfer gases easily, we have other structures that are functioning in those roles, right? The alveolar macrophages are going to take over that immune sort of protective role, and the alveolar 2 cells, the type 2 alveolar cells, are going to take over in secreting surfactant that helps to keep this part of the lungs open and patent. Continuing on here, describing the epithelia of the respiratory zone, this is called the respiratory membrane. And just to kind of clarify the terminology here, remember we had the respiratory tract, which was further divided into conducting zone and respiratory zone. And then within the respiratory zone, we have the respiratory membrane. So make sure you're keeping this terminology sort of separate. So the respiratory membrane is really formed by the epithelial layer of the alveolar cells, the type 1 cells that are lining the alveoli, as well as the endothelial cells of the capillary that's coming in really close contact with the alveoli, and by extension, the type 1 alveolar cells. Okay, so we've got the capillaries that are overlaying the alveolar sacs. And so that brings the endothelial cell of that capillary right up against the type 1 alveolar cell. Now, each of these cells in any other location in the body would have their own basement membrane, but because we want to eliminate any bulky structures in the way and we want to adapt this region for gas exchange, we have the fusion of the basement membrane of the type 1 cells with the basement membrane of the endothelial cells to create one fused barrier that kind of decreases the amount of stuff that gases have to kind of obstruct that exchange. Okay, and so we have a very thin layer here that creates that respiratory membrane, right? We have the epithelial cell, right, that type 1 alveolar cell. We've got the endothelial cell of the capillary, and then we have a combined or fused basement membrane. And that constitutes the very thin respiratory membrane. Looking a little bit closer here, another electron micrograph, we're seeing the opening of the bronchiole here. And then we can see the opening of these alveoli. So this is what I mean by keeping them nice and open and patent and preventing them from collapsing down on themselves, which they would typically try to do if there was not any surfactant lining the inside of these alveoli. All right. The last set of things that we'll speak about here are some of the other structures that play a role in respiration, really ventilation. And so these are the thoracic cavity structures. We've got the chest wall, and we talked about these structures quite nicely. We talked about these structures in lab before now, so you should have an understanding of the anatomy of the thoracic cavity, the anatomy of the chest wall, the diaphragm, rib cage, and so on. And so these help to provide an airtight seal as well as protect the lungs. So one, that airtight seal is that the pleura, so the pleura is the double-walled membrane that lines the lungs, is tightly adhered, the parietal pleura is tightly adhered to the thoracic cavity. And so that's what we mean by that airtight seal, right? Preventing any air from getting into that small space between chest wall and lung. And then chest wall also plays a protective measure in the lungs. As we talked about earlier, there's no smooth muscle down in the alveolar, there's no cartilage down in the alveolar. And so we really want to protect those lungs from any type of external injury. And so having this thoracic cavity, which is formed by the rib cage, sort of in the peripheral aspects, by the sternum anteriorly, and then by the thoracic vertebra posteriorly, is forming a structural barrier, right? A structural protection for the very delicate lungs that are underneath. We've also got muscles that are helping to form the chest wall, the internal intercostals, the external intercostals. The diaphragm also helps perform that, to provide that airtight seal, as well as play a protective role for the lungs. And then speaking more about the pleura here. So the pleura, again, is this double-walled membrane. It's sometimes very hard to visualize. And so next week, I'll probably bring in my Ziploc bags the way I normally do to kind of demonstrate what the pleura actually looks like. But it's this double-walled membrane. So if you were to take your fist and push it into a balloon, the part of the balloon that's covering your fist is the visceral pleura, and the part of the balloon that's outward is going to be the parietal pleura. And that's what we mean by that double-walled membrane, right? And I hope that visual kind of makes sense. And so the parietal pleura is tightly adhered to the external structures, the diaphragm inferiorly, the thoracic cavity externally, and the visceral pleura is going to be tightly adhered to the lung itself. And that creates this space in between those two linings, right, visceral and parietal, that's called the intrapleural space. Now, there should never be air in the intrapleural space. We'll talk about why that's important later on. This is sort of a negative pressure region that usually only has a very small amount of intrapleural fluid, about 50 milliliters of fluid, that helps to keep that region connected, right? That fluid that's sitting in between that layer is going to keep the parietal pleura of the chest wall, the visceral pleura of the lung tightly adhered to each other and prevent any air from becoming present in that space, really providing this negative environment, negative pressure region in that intrapleural cavity, that intrapleural space. Okay. And that'll make a lot more sense as we go on and speak about the pressures, which are really important for moving of oxygen, as we talked about a little earlier. So the last thing we'll say here is the sort of just clarifying and looking at some of the structures of the thoracic cavity here. So we've got the intercostals, right, the muscles that are studding or interleaving in between each of our ribs here. We've also got the costal cartilage. So remember, this is not a rigid fixed connection. The sternum is not directly articulating with the ribs. We do have cartilage to allow for the expansibility and the flexibility of the thoracic cavity. We've also got the diaphragm here inferiorly. Does anyone know what state of respiration we're in when the diaphragm is nice and rounded like this? So are we in inspiration or expiration when the diaphragm is nice and curved? So I'm seeing expiration, but that is not true. We're actually in inspiration, okay? We're in inspiration. Remember, when we're bringing air in, excuse me, I'm so wrong, guys. This is correct. Expiration is correct. So when we're expiring, we're actually allowing for that negative pressure in the lungs, and that's going to move air back out into our external environment. Okay, I apologize. So you're absolutely correct. When the diaphragm is nice and rounded, that's expiration. And then when the diaphragm is flattened out, that is actually inspiration. Okay, that's when you put that pressure on the abdominal contents. We spoke about the respiratory pump in that when we inspire, we increase the amount of pressure on the abdominal organs, and that happens with that flattening out of the diaphragm that we see during inspiration, excuse me. All right, and then the final thing I want to say here on this slide is just to observe that intrapleural space, that negative pressure space in between the visceral pleura. So the visceral pleura tightly adhere to the lungs, and we can see a close-up of that here. And then the parietal pleura tightly adhere to the thoracic wall. And so that creates this intrapleural space where we have a small amount of intrapleural fluid. And again, that fluid is just kind of keeping those two layers adhered to each other. It's also providing some of the lubrication that's needed so that we can actually move the lungs with respiration, okay? We should never, ever, ever have air in this space. That's called a pneumothorax. And that is actually going to make it hard for the lungs to inflate. So anytime air is present in this intrapleural space, the lung automatically collapses, okay? And so the lungs are actually nicely inflated because there's air in them. And if we bring air into this space, we throw off the pressures. We'll describe this later on, but we throw off those pressures and the lung will completely collapse onto itself and make it really hard to breathe. This can be a life-threatening emergency. And so the quickest way to alleviate this or to fix this is to actually puncture the thoracic wall, let that air out. And in fact, I've actually seen this being done in the emergency room. And you just hear this big deflation, like if you were to pop a balloon, when all that air comes out of that intrapleural space, and then the lung can once again inflate.